Hi everyone, my name's Gill Hebar. I'm the advanced practitioner in the Liverpool Ocular Oncology service. I started nursing in 1982, where I did my general nurse training, and then I went into specialise in ophthalmology in 1985, where I've been ever since. It's sort of oncology, should I say, rather than ocular oncology, but oncology is something that has been my passion throughout nursing, really. But being in ophthalmology, I didn't really think I'd ever get the opportunity to work with patients, oncology patients. But when the opportunity arose, when Professor D'Amato was here in 2006, that's when I applied for the role, and I've been in ocular oncology ever since. And I feel that I've arrived with my job. I absolutely love it, and I'm very passionate. And we, as a team, we all try and offer the best experience and care for the patient, really. So today, I just want to give you a brief overview really of what to expect in the ocular oncology service when you attend the new patient clinic. So we will, once we receive the referral letter from the local ophthalmologist, we stamp date it, and then the consultant oncologist, either Professor Hyman or Miss Hussain, will then actually review that letter. Once they've reviewed the letter, it's then given a date to attend either a new patient clinic or to be seen urgently. We do like to see patients within 2 weeks of receiving the referral. Sometimes that's a little bit difficult with the number of referrals that we do receive, but if anybody's classed as urgent after the consultant sees them, we will make sure we get that patient in, even if it means overbooking a clinic. So I don't know if you know that the oncology service is on a 62-day cancer pathway, where all patients have to be seen and treated within that 62 days. So it is a target that we actually do achieve. I don't think we've had any breaches of that target. Just for reassurance for yourselves. And then it's allocated a date by, you're allocated a date by the secretary, Jenny, in the office. And then what they will do, they will compile a letter. The letter contains the, obviously, date and time for the appointment. It contains telephone numbers for myself, for Gary Cheetham, who's our data manager, and again for Jenny, the secretary. It also contains information for how to book through us hotel accommodation if you obviously we see patients from all over the country, so the telephone number is on that for you to ring us if you need help with accommodation coming up to Liverpool. Now that has currently just changed within the trust, and we can only book accommodation if the patient lives further than 3 hours away. But we can help, giving a map or a list of hotels available for you in Liverpool. There is hotel accommodation as well, so don't panic about things. You can always, we can see what we can do to, try and help. We don't want you to stress about that, really. The patient will also, you'll also be sent a patient guidebook, which it's like a booklet, and it contains a map of the hospital. It contains what to do in Liverpool, train station, again hotels, and it's got a whole list of who's who, what treatments are available. It really is quite an in-depth book. It's a colourful book as well. We've had different feedback about this. Some patients love it, and they feel that it's prepared them for when they come to the clinic. Some people absolutely hate it. They can't read it because it's too much information. Again, everybody's different. And with this book as well, you can either choose to keep the booklet or you can hand it back to us, whichever you feel. But like I say, majority of patients do like the booklet. So when you get to Liverpool, you'll be coming to the Clinical Eye Research Centre. It is quite well signposted. It's got the yellow signs and it's got the Clinical Eye Research Centre, and it's usually on the first floor. There's lift access to us as well. So when you get to the clinic, you can see there's a picture. It's only a black and white picture on the presentation. But when you get there, you'll be greeted by Sean, who's our receptionist. And Sean will ask you your a few personal details. So he'll check that we've got the correct GP. He'll check that your date of birth is correct and your address, and he will also check your telephone numbers so that if we do need to contact you, we've got everything on the system. At this point as well, we will give out what we call a medical questionnaire. Again, some people like to do it, some people don't like to do it. It isn't you know, a problem if you feel, no, I don't want to, I can't think about anything. But what this medical questionnaire is it just gives you time to think about any previous surgeries, any previous medical conditions, any family history of anything, what medication you're on. And all this is when you see one of the doctors, it just makes your history taking quicker because they can look through and you've actually thought yourself and documented everything, you know. And if you do forget things, it doesn't matter because, you know, there's always other opportunities to chat about these things. Currently with COVID, we're asking, the trust actually are asking relatives not to attend with the patient, but we feel quite strongly about this, that, you know, it's a cancer service. There's a possibility of a cancer diagnosis, so that patient needs that, all the support they can get. So we do say just one relative can come with the patient, and we you know, we're hot on socially distancing. We're all wearing masks, aprons, and when you're being examined, we've got the correct PPE on for you. So please feel free to bring a relative. That's not a problem. So once you've filled in your questionnaire, there may be a little bit of a wait, depending on how many patients are. If you come for 8 o'clock, you'll be in quickly. But if you're one of the patients, we give appointment times up to about 11:30. So depends what time you come and where you are in the system. So initially, the first assessment you'll have is a visual acuity. So that's testing how much you can see, how far you can see. And it's a distance chart that we use, and it's called a logMAR visual acuity. And it's slightly different than some of the other charts that you possibly use, where there's more letters on the chart, and it gives them a more accurate explanation of your vision. What was this? So we test each eye separately. So we will test you with glasses on, if you wear glasses for distance, or we'll test you with glasses off, obviously, and then we'll use a pinhole vision. You've probably all used this before when you've had your experience in your local ophthalmology department. We'll also check the pressure in your eye using what we call a toner pen. This is a machine that touches very gently, very lightly on the cornea, but we do put drops in, anaesthetic drops in, just to numb your eye so you can't feel anything. We're just in the process of buying some non-contact toner pens, so that will be a better experience for the patient, really. Once we've checked the pressure and recorded everything, then we need to check whether we need to dilate your pupil or whether we don't dilate your pupil, because if you've got a concern on the iris, the coloured part of the eye, then obviously if we dilate that, we can't see the full picture, we can't see the iris because it'll have bunched up and opened. So we need to take photographs of your iris undilated. If you've got any concern at the back of the eye, then that's when we'll dilate your pupil, and it gives us the opportunity to check what we call is the fundus, which is the retina in the back of the eye. So once you're dilating, you probably have to wait about 15 minutes for that to work. And then the next person you'll see will be our photographer. It's either Gill or Bill that's with us at the minute. And what they'll do is they'll take you through whichever camera is appropriate for whichever condition you've got. So basically, if you've got a tumour at the back of the eye in what we call the choroid, or the retina, or anyway, at the back of the eye, we use a machine called the Optos California. And what this is you pop your chin on the machine. I've put pictures on the thing so you can see. Pop your chin on the machine, and it's a scan that they take of the back of your eye. And the good thing about the Optos California is it gives a wide angle view of your eye, so it can sort of see round the corner as well of the globe. A lot of opticians only have cameras where you can see the optic nerve and the macula, but the benefit of this is, like I say, you can see 360. So once they've done a colour fundus photograph, they will take you through to do an OCT scan, so an optical coherence tomography scan. And this actually takes a cross section of your retina. It focuses, we like to look at the macula as well. The macula is what you use to see faces and read fine detail. So we'll look at the macula, and we'll also take a cross section of the tumour itself as well. And with this one, we look to see whether, you know, clinical features and all the clinical features that are picked up aid the consultant with the diagnosis. If you have an issue with the conjunctiva or the front of the eye, the anterior segment of the eye, or the iris, as I mentioned before, we will take what we call a top-com photograph, and this is just an image of the front of the eye. And what they'll do is they'll ask you to look in different quadrants to take images, quite a few images really, looking up, looking down, up and right, down and left, to the side, so to make sure that they capture the whole. There may be a possibility that we may have to just what we call evert the lid if we're concerned about anything underneath the lid. Again, it's not a painful procedure. We put drops in to numb and just get a little cotton bud and just turn the lid over, and then that allows the photographer to take those images. So it's fairly painless procedures really. So once we've gathered all the images together, then you'll then see the, I don't want to say junior doctor because they're not really junior. It's a fellow and a registrar that we usually have in clinic. So they normally take the basic assessment and take a history. So it then helps the consultant throughout the examination. So the doctor, again, he'll examine your eye on the slit lamp. If there's anything at the back of the eye, obviously the choroid, then he'll use a lens to have a look at the back. They may put what we call a HATI, so indirect ophthalmoscope, so it's a light on his head and shine you put a lens in front of your eye, and again that gives a wide image of the fundus as well. If there's anything on the conjunctiva again or on the iris, he'll just check the anterior segment, but usually he checks both eyes and documents all his findings on the system. We've moved on to electronic systems now, so that's been a challenge in itself, but now it seems to be working well, and everything's easy to find electronically. So following that examination, the junior doctor will do an ultrasound scan, and the ultrasound scan is, again, it's a probe. We put some jelly on the probe, and then it's a bit like when you know, we just put the ultrasound scan on the front of the eye, and that gives a cross section again of the tumour, horizontal and transverse, and that's used to measure the size of the tumour, used again for both anterior and posterior tumours. So once the doctor has seen you, there's a few little steps, but once the doctor's seen you, then there's a wait then to see the consultant. So we've got 2 consultants in the team. There's Professor Hyman, who's been with us for about 15 years in ocular oncology, and then we've got Miss Hussein, who works alongside him. I think she's been about 5 years in the service. They're both ocular oncologists, but they also both specialise in vitreoretinal surgery as well, which we feel is beneficial to ocular oncology because of the extra surgeries that we offer here in the biopsies. So, you know, that's their speciality, dual speciality. So when you see the consultant, you're called into the room and he introduces himself. You sit in a reclining chair. He'll again do a full assessment of the eye. He'll check what the doctor's found, and then sort of the whole process is repeated. So what the doctor has done, the consultant will carry out as well. And then he'll also take an ultrasound scan. Once he's got all the images together, then what we tend to do is ask the relative to sit alongside the patient so that you know, you've got that support as well, and myself or one of the other specialist nurses are in the room at the back, so we're there to support you as well with everything. The consultant will then have a chat with you about what he feels is going, you know, what the diagnosis is, but he'll also record the consultation on a disc so that you've got that to listen to when you get home, because any sort of diagnosis, any cancer diagnosis, I think you just listen to that one word, cancer, and then everything just goes out of the window. You can't take anything in, and sometimes, you know, you just blank. It's a blank. So yeah. So once the consultant's given you the diagnosis, it gives you some time to think about what you know your preferred treatment as well, if there are treatment options. But more often than not, it will steer you in the right direction, because these days, you know, it is patient's decisions. We don't tell you what to do unless we feel that we have to, that it's in the best interest of yourself, really. Obviously, it's a difficult time, very difficult time, and the professor will give you time to sit, just reflect a little bit, and then when you're ready, he will introduce you to myself or the other specialist nurses, and we'll take you into another room, and we'll have a chat about exactly what he's just gone over with you again, because it's a lot to take in. So at that time, we'll sort of offer you, if you're happy to carry on straight away, or if you need a minute, or if you need to go off for a drink or some fresh air, whatever you feel, we work with you and support whatever you want to do. So basically, when you're in the counselling room, we will give you some information leaflets about the surgery that you've chosen. So we will give you information leaflets about the surgery that you will be having. Obviously, there's different types of surgery. There would be plaque radiotherapy, there would be proton beam radiotherapy, where we'd have to insert some little markers into your eye, which prepares you for the proton beam radiotherapy. Liverpool offer a transscleral local resection that is for large tumours, because if a patient doesn't want to have their eye removed and the large tumour is in a position where it's easy accessible, we would offer the transscleral local resection. We also offer what we call an endoresection, where we chop the tumour up into little bits and hoover it out, simply. It's all explained in the book that you will receive. And there may be an option as well of a transscleral biopsy, because sometimes some of the lesions are a little bit, we don't know there and then because of the clinical features whether they are a melanoma or whether they are a metastases or whether it's something else which could be benign. So we would offer a biopsy as well for diagnostic purposes. So again, like I mentioned, we'd give you the information leaflets. We'd also give you contact details of our health psychologist, Laura, she's currently working from home, but she will contact yourself either before surgery if you need that extra support, or after surgery, usually within 2 weeks post-surgery, she'll contact you to see whether you need that extra support. But again, I always say to the patients, contact me. My telephone number is on the back of the information sheets. Let me be the first port of call for anything that you're concerned about. And feel free, no question is a silly question, so do not sit there worrying about anything. Once we've given all the information leaflets, I ask the patient, are you happy to carry on with the pre-op assessment, and we do all that today, or would you like to come back another day before the surgery is, the day before the surgery is planned? But majority do like to get it over with in one day, then it's all done and dusted and everything's prepared, ready for surgery. So with the pre-assessment, what we do, we just send you off for a blood test, an ECG. If you've got any respiratory problems, we'll organise a respiratory function test. If you've got any heart problems, pacemakers, anything in particular, or chest problem where we need an x-ray, we'll organise a chest x-ray and we'll organise testing of your pacemaker as well. So it's good if you can carry the card, if you have got a pacemaker, if you can carry the card of the details with you to the hospital, so we've got that information with us, because we need to enter that into the system. So if you're having proton beam radiotherapy, we need to send you to the optician so that you can have what we call a biometry, which is a measurement of the length of your eye, and that aids the physicists in Clatterbridge to calculate and work out the treatment that the power of the treatment that you're going to receive. And basically that's it really. We'll set a date for surgery. Again, we've got to do it within the 62-day pathway, but if you've got a holiday, well, not likely at the minute, but if there's anything commitments that you've got beforehand, we can work around that. But usually, COVID's put a bit of a strain on the service at the minute, really, because we like to operate the following day. That's what we used to do. So patients coming from a long distance away, we will keep them in the hotel the night before and operate the next day. But now, with the COVID, we've got to send you away, tell you to self-isolate for 3 days, and then bring you back the day before surgery, usually early in the morning, and do a rapid COVID swab so that the result is back for the next day for when you do attend for your surgery. And basically that's it, really. Everybody's here to support you. We're always on the telephone. Please don't hesitate to ring us at any time. And we're all a nice team. We all work together. And the main aim is you, looking after you. You're the priority. Okay, thank you.
Thank you for that, Jill. That was absolutely amazing, and a lot of really valuable information that I know people will appreciate hearing. Can you just tell us what people's next appointments look like? So once they've received their diagnosis, they've had their treatment, and then they normally come back, I believe, sort of 6 months later. What kind of tests and things happen on that next appointment?
So basically, again, the tests that they had on the first appointment will be repeated. So they'll have the visual acuity, they'll have their intraocular pressure checked again, dilated or not dilated. They'll have the photographs, the images, the Optos, TopCon and OCT. That will be done at every visit that they come to us. That's like the law. In other words, that's what. So then they'll either, at that visit, they'll either see a nurse, a junior doctor, or a consultant. If it's straightforward, usually at the first visit post-op, you're not going to see a great deal of change within the tumour. What we're really looking for at that clinic appointment is that it's either stayed the same size or it's not gone any bigger, because we don't want to, obviously, that's what we don't want to see, it's that the tumour's grown. Usually with plaque radiotherapy, the tumour will have shrunk more than it would with proton beam radiotherapy, because the plaque is a little bit of a stronger, more powerful treatment. And what we do like to see is around the tumour is a footprint of where the plaque's been, which that reassures us to show that the tumour is contained within that area. With the proton beam radiotherapy, what we like to see is, as I've mentioned, that the tumour is the same, it's not any bigger, but it's unlikely that after proton beam, because it's a milder radiotherapy, that the tumour will not have shrunk any, it will not have got any smaller. But we're happy with that, we just like to see it stable. Again, you'll have an ultrasound scan to check the thickness of the tumour. Usually it will have shrunk a little bit in the thickness, it would have got smaller. But like I say, the tumours will never disappear. It just gets smaller and smaller over the visits that you come to us. And usually within about 12 months, 18 months, we then can start seeing changes. Which is quite reassuring. It is a reassuring treatment, really, it is good. But I always remember what one of the other professor used to say is, it leaves like a pile of soot. The tumour is just like a pile of soot, so it never goes away, it's just like a scar, pile of soot. And that's what we're monitoring. And usually we see you every 6 months. and we ask your local hospital to review you in between, because it's still joint care. A lot of the local hospitals sort of say, oh no, you've been referred to Liverpool now, so we don't need to see you, but they actually do need to see you as well. Because eye cancer is a rare cancer, so they need to, you know, get to know what these rare cancers look like. And eventually, once we feel that the patient is stable and the chance of recurrence is less than 1%, we will then be discharging you back to your local hospital for monitoring. But don't ever feel that you've been discharged and that's it. We're always open. You can always ring us at any time if you're concerned about anything. Email, and if your consultant locally is concerned, he will always refer you back to us for anything whatsoever.